Greetings, all. My name is Natasha Murphy, Health Policy Director at the Center for American Progress, and I'd like to welcome and thank you for joining us for today's virtual event. The Big Beautiful Bill attacks Medicare recipients and people with disabilities by driving up costs and cutting benefits. Over the next hour, a panel of experts, advocates, and storytellers will discuss the wide-ranging impacts of Congressional Republicans' budget reconciliation bill on older adults, people with disabilities, and other Medicare enrollees. Today, we are joined by David Lipschitz, co-director at the Center for Medicare Advocacy, Galila Selassie, senior attorney at Justice and Aging, Nicole Jorwick, Chief Program Officer at Caring Across Generations, and Emma Bowser, mother, educator, and advocate. But before we get started, a few virtual housekeeping items. Today's session is being recorded. The recording and summative recap will be available on the CAP website shortly. And to ensure that today's event is accessible, closed captioning is available. You can access this feature by clicking on the closed caption button at the bottom of your Zoom screen. And finally, please use the Q&A feature to submit your questions. We will try to answer as many as we can today. Now, I am pleased to turn the virtual mic over to CAP Senior Fellow and moderator of today's discussion, Don Berwick.
Thank you very much, Natasha, and thank you all for joining us for what I think is a really, really important discussion, especially at this time. I think it's sort of a time-honored feature in human history that people who want to accrete power create an enemy. If you can create the sense that there is an other, not us, and that the other is somehow harming us, you can then recruit support and grow your own power. In this country, Medicaid, to some extent, has come to serve that purpose for some in the policy debate today. Congress searching for offsets to fund tax breaks for wealthier people is looking for the money in the worst possible place. Find the money in Medicaid, reduce Medicaid support by $800 billion over 10 years. Let's step back a minute and look at what that means. Medicare is perhaps one of the most popular social programs in American history. Tremendous support, a commitment to universal coverage for people who are in their aging years. And its partner program, Medicaid, although less generally regarded by the public with so much popularity, is equally essential. In fact, I might argue more essential. When I ran Medicare and Medicaid in the Obama administration, I could see how crucial Medicaid was to the social safety net and the well-being of families and communities in our country. Those who want to harm Medicaid are creating myths. The durable myth is of Medicaid as a playground for abuse or for the transfer of money to undeserving poor. And thus, we see proposals for work requirements, increased co-payments, reduced payments through the Medicaid system in legislation making its way through our popular discussions today. On the Medicare side, the illusion is that somehow in the damage to Medicaid, Medicare, this extraordinarily popular program, will remain unscathed and protected despite enormous cutbacks in Medicaid funding. These are untruths. And today's conversation, I think, will help with the testimony of some real experts, both people with lived experience and those who study the phenomenology of public financing of healthcare in America. We're going to see those untruths unfold. The fact is that when Medicaid is harmed, we are all harmed, including especially people on Medicare. When hospitals close because of Medicaid cutbacks, those hospitals close for everyone in the communities served. When nursing home support is cut back through cuts in Medicaid, nursing homes get worse, they get less available. And today, the Medicaid system, which funds about half of the nursing home coverage, even more in the United States, will leave families bare of support for the care of people in aging years. When children are harmed through cutbacks in Medicaid support to kids, that echoes throughout life in terms of the health and well-being of communities. There's a domino effect of all of this into Medicare, which our panelists will help us understand. And finally, when Medicaid is cut back, states end up holding the bag, and states are the support system for care of all sorts, social support for communities. So make no mistake about it, the big, beautiful bill, which harms Medicaid potentially irrecoverably, also harms Medicare, also harms communities, also harms people with disabilities. And in this session, we're going to see how that cascade of effect occurs. We hope that this meeting will help correct some of those myths and restore an understanding of how we are really all in it together. You can't look at the proposals to cut Medicaid as an isolated thing that affects others, affects them. No, no, no. It affects all of us. It's part of the American social safety net. And in particular, it affects Medicare, which is the program upon which aging people in this country depend, essentially. With that said, let's turn to the experts. I'd like to welcome remarks on the Medicare cuts to begin with from David Lipschutz. David, the mic is yours.
Thank you very much, Don. Thank you to the Center for American Progress for having me, and thank you for all of you in attendance. As Don outlined, much of the attention of this bill has been on the impacts that it would have on Medicaid, rightly so. But our purpose today is to show that there are significant impacts on the Medicare program and the people that it covers, both directly and indirectly, specifically on older adults and certain individuals with disabilities. One theme we wish to convey is that a cut to Medicaid is a cut to Medicare. In a few minutes, Galila is going to talk about how these cuts impact people who have both Medicare and Medicaid, known as dual eligibles. I'm going to start by addressing a couple of other impacts, beginning with who would be terminated from Medicare coverage if this bill were to pass, then a few words about nursing homes, and then some general comments about the widespread impacts. First, if this bill passes, 1 year following passage, there will be groups of people already appropriately and legally on Medicare that will be stripped from coverage. Certain groups of lawfully present immigrants, many of whom worked and paid into Medicare for decades, will lose coverage. Undocumented immigrants are not eligible for Medicare. Let me repeat that. Undocumented immigrants are not eligible for Medicare. Under current law, legally present non-citizens who are older and disabled can qualify for Medicare by either having the requisite or sufficient work history under Social Security, or residing in the U.S. for at least 5 years and being a lawful permanent resident. For most intents and purposes, that means a green card holder. This proposed bill would upend that framework by barring Medicare eligibility for many of the immigrants who currently qualify through their own work experience. Groups that would lose Medicare eligibility include individuals with temporary protected status, refugees, asylees, trafficking survivors, domestic violence survivors, and other statuses under which immigrants live, work, and contribute to Social Security and Medicare. Their lawful immigration status is often based on severe hardship that they endured before arriving in the U.S. But in many cases, these individuals don't have a pathway to a green card or citizenship. So the ability to qualify for Medicare based on work history is critical for their access to medical care. This bill, if passed, would mark the first time that we are aware of that Medicare coverage would be taken away from certain groups of people, rather than, as has been the case in the past, expanded to cover certain groups of people, such as individuals with disabilities, individuals with end-stage renal disease, and accelerated eligibility for people with ALS. Second, a few words about nursing homes. Medicare can pay up to 100 days in a nursing facility as long as someone is getting daily skilled care and meets certain other requirements, although Medicare usually covers much shorter stays. Medicaid is primary payer for 63% of nursing facility residents, including many with Medicare. There's a provision in this bill that would impact Medicare beneficiaries who need nursing facility care, even if they don't have Medicaid. This bill scraps a 2024 nursing home staffing rule that was aimed at improving care for residents and supporting nursing home workers. This rule emerged in the wake of the pandemic and the impacts that we saw that the pandemic had on individuals in long-term care. And among other things, would have required a registered nurse to be on site at a facility 24/7, and that each resident receive a requisite number of hours per day of nursing home care, among other changes. This same rule is currently put on hold by different courts, but the bill in Congress would rescind the rule altogether. Researchers at the University of Pennsylvania have estimated that if this staffing rule were implemented, it would save 13,000 residents' lives each year. There are other impacts of the bill on those who rely on Medicaid for long-term care in nursing facilities, as well as those in the community and who provide individuals with care, as Nicole will talk about more soon. The third and final point I want to make really echoes something that Don talked about, is that in our patchwork healthcare system, many pieces of the quilt are interconnected. You pull on one thread and it unravels elsewhere. States that see reduced Medicaid payments will have to make some tough choices about how to compensate for these cuts, including whether and what Medicaid services they might have to reduce, which will certainly have an impact on people who also have Medicare. Among other things, these cuts to Medicaid and the Affordable Care Act will have impacts on the very same providers who provide care to Medicare beneficiaries. For example, recent research out of the University of North Carolina concluded that the healthcare cuts in this bill would result in over $50 billion in reduced federal Medicaid spending on rural hospitals over the next 10 years, placing over 300 rural hospitals across the U.S. at disproportionate risk of closure, conversion, or service reductions. It will not just be people who have Medicaid that will be impacted by hospital or clinic closures or reductions in access to other services. These cuts impact entire communities, anyone seeking care from these providers. So as we proceed in our discussion today, I ask you to keep in mind the ripple effects of these massive changes to the rest of the healthcare system, both intended and unintended. With that, I will pass it over to Galila.
Thank you so much, David. I'm Galila Selassie from Justice and Aging, and really appreciate being here today and sharing just how crucial Medicaid is for older adults. We often hear about Medicare, and as David said, Medicare is really, really vital for our populations. Medicaid also needs to be said in that same breath. As David mentioned, a cut to Medicare, or a cut to Medicaid is a cut to Medicare. There are more than 12 million older adults and people with disabilities duly enrolled in Medicaid and Medicare. Nearly 1/3 of all Medicaid funding goes towards Medicare enrollees. These programs are inexplicably linked, and you can't make the largest cuts in history to Medicaid without touching the Medicare population. Going back to that duly eligible population, those millions and millions of older adults and people with disabilities who are very low income and limited asset, who are duly enrolled in Medicaid and Medicare. There are a couple rules. David already mentioned the nursing home staffing rule that was projected to save 13,000 lives a year, mostly being older adults who are in nursing homes that are understaffed and therefore dying or facing hospitalizations because of that understaffing. And then there are also eligibility and enrollment rules that were published in the last couple of years that would protect people on Medicaid from losing their coverage due to these arbitrary administrative barriers, which we've seen many, many times before, particularly towards the end of after COVID, when people were getting through an unwinding process and getting and potentially getting reevaluated for their eligibility. We saw people losing coverage for the most ridiculous reasons. If they've moved, something was lost in the mail. The state might have the ability to verify their assets, but still sent massive amounts of burdensome paperwork things like that. And so these are people who are actually eligible but can't get their health care, and very often don't know it until they're at the pharmacy trying to get life-saving medication or at the hospital trying to get treatment. These rules, these Medicaid rules, the eligibility enrollment rules, would have protected those individuals and make sure they don't lose their coverage for those arbitrary reasons. One big aspect of the rule was especially focused on the dually eligible Medicaid, Medicare population. They are individuals who are enrolled in the Medicare Savings Program, or MSPs, which are administered by state Medicaid agencies. MSPs are especially crucial because they help pay for Medicare. They subsidize some of the Medicare costs for older adults and people with disabilities who are living just right at or below the federal poverty level and who have extremely limited assets. As wonderful as Medicare is and as great of a program it is also very expensive for some people, potentially paying hundreds of dollars a month in premiums or thousands of dollars a month in out-of-pocket costs. Medicare is only so great as somebody can afford it. And so for these low-income duals, having that MSP program to help pay for their premiums, pay for their out-of-pocket costs is incredibly important. Otherwise, they would not have access to their Medicare, excuse me. And so for more than 10 million MSP enrollees, that's 1 in 5 Medicare enrollees who need MSP to afford their Medicare, to get their treatments, to visit their doctors, to get their cancer screenings, to get all of these vital services. And they are not able to afford these wonderful services that Medicare provides if not for MSPs. This bill would effectively rescind those rules and those protections. It would lead to almost 1 million low-income, dually eligible individuals from losing their Medicare Savings Program funding. And in a few states, and this is data from MNATS, a few states, particularly Georgia, Florida, and Texas, which have a high population of lower income older adults, there'd be more than 250,000 individuals just in those 3 states who would lose their MSP savings and would see those much, much higher Medicare costs. And so in that way, you have to wonder, why would we take coverage from any Medicare and Medicaid population, but also recognizing how important Medicaid is for older adults, for people with disabilities, for Medicare enrollees. And then before I turn it over to Nicole, I know she's going to talk a lot more about some of the additional dangers facing the broader Medicaid population, but I would be remiss if I didn't mention how important caregivers, both family caregivers and the direct care workforce is for older adults. As David mentioned, Medicaid is a massive, massive program for hospitals, clinics, providers. These cuts would impact everybody who uses those services. Older adults in particular rely on care workers, informal family caregivers, as well as direct care workers. And any of these cuts that are attempted to be made to carve out older adults, like those that are impacting the Medicaid expansion population or others, still have an impact on older adults. Our population relies on younger people or people who might not have a disability, but are risking their own health and their well-being for near poverty level wages or are not entering the workforce to care for a senior. And that is really important, that we don't throw one of our vital Medicaid populations under the bus because they are so, so, so crucial for the work that they do and the services that they provide. And so with that, I will pass it over to Nicole.
Thanks so much, Galila, and glad to be here. I'm Nicole Jorwick, and I'm going to talk a little bit more about Medicaid and the ways that it's important for people with disabilities. I do want to name that because of all of the reasons that Galila just stated, Medicare also is important, but the direct cuts that are being proposed to the Medicaid program would have a massive and outsized impact on people with disabilities, and particularly on access to home and community-based services. I'm going to talk about some facts and how this program works, but I want to start on a personal note, which is that my brother Chris is 35 and has autism and receives Medicaid home and community-based services in the state of Illinois, where he lives and where we live. And he has, as usual, is the best advocate in our family. And so I wanted to start with words from him. He says that Medicaid is a lifeline for people like him, that Medicaid gives his life color, that today it meant going to the park with his niece and nephew and care worker, and every day it means freedom. And that's really the reality for so many people with disabilities and older adults. Medicaid is a lifeline for people with disabilities and older adults all over the country. Medicare and private insurance largely do not cover long-term care, and David went into some of the specifics on that. And Medicaid does fill the gap, accounting for 61% of all long-term care spending in the United States and nearly 70% for home care spending. I want to highlight that piece because we know from polling that we've done at Caring Across Generations that 95% of people with disabilities want to be living in their homes and communities, but that's not where the funding is. And with these massive cuts being contemplated, it would have a big impact on access to the services. And as Galila mentioned in her closing remarks, Medicaid is also the primary source of funding for direct care worker wages. Medicaid also provides the health care for so many of those workers and also family caregivers who are filling in the gaps to services. So Medicaid really has a triple impact on people with disabilities and their family caregivers. 11 million people with disabilities rely on Medicaid for healthcare services as well as home and community-based services. And again, is the main funder in this country for long-term care, specifically home and community-based services. Medicaid is this healthcare program and provides so many supports and services, but what we've seen and what's been really good to see is that so many people are starting to wake up to all the different things that Medicaid is outside of just this healthcare program. It is that primary payer for home and community-based services, and 7.8 million people rely on Medicaid for aging and disability care in their home. One of the reasons why the disability community has really needed to, and the same was true in 2017 when the disability community rose up against cuts of really similar size and nature, is because while 6% of Medicaid enrollees use long-term care, it accounts for about 34% of the spending. And that's because these are not acute one-time services. These are services that occur over time. And that's also why people with disabilities and the disability community needs to stay so engaged. Medicaid is a state and federal partnership. It means that any state knows that if they invest $1 into the Medicaid program, that they are going to get that guaranteed match rate back. But it is a program that is overseen by the federal law. And the federal law creates some services as mandatory and some services as optional. Mandatory services include traditional healthcare services, some of those nursing home services, and it also includes optional services. And when home and community-based services were created in 1981, while they are not optional to the people who need them, they were created as optional services. What that means is that states can cap how many people that they're serving, and they already do. That's why we actually already have 700,000 people on a waiting list, over 700,000 people on a waiting list for home and community-based services. With cuts of these size, there's going to be an outsized impact on those optional services because states will not have an option when you have cuts of over $800 billion onto whether they're cutting mandatory versus optional. They're going to have to go to optional places first. That means things like job coaching, community volunteering, day programs, home care. That's all going to be at risk. That's what's at stake right now for people with disabilities. The 11 million people with disabilities who rely on the program is that there is going to be a real lack of access to home and community-based services. We know that there's going to be cuts to optional services, cuts to provider rates, which means that workforce shortages are only going to get worse, cuts to enrollment, meaning waiting lists are going to get bad, and a real threat to unnecessary and more expensive institutionalization. This is all at a time when Medicaid is actually extremely popular. It's the first time in my career that we've seen Medicaid at almost as popular and on par with Medicare in terms of its popularity, which is why it's really unclear why Medicaid continues to be looked at as a piggy bank when Congress is looking to pay for different priorities. What we do know is that actually the vast majority of people, 82% of adults, oppose cuts to Medicaid spending across the political spectrum. That's why we need to make sure that we're remembering people like my brother Chris, people with disabilities who would be outsized, have an outsized impact on this bill. And now it's my pleasure to turn it over to Emma, who's going to talk more about the real life impact of these cuts and what's being proposed.
Hi, I'm Emma Boza. I live in Northwest Iowa, very rural. My husband and I have 2 children. Our youngest is 14 and she has Down syndrome. And so she qualifies for Medicaid through a waiver with that diagnosis. With Down syndrome, it's not always just that diagnosis. She has 10 plus other specialists and doctors that she sees. So we're looking at a lot of doctor's appointments and doctor bills and all of that. She does speech and OT private, and she does it through school-based services. She has a one-to-one at school. And then other things those are all Medicaid covered services. And I guess I should go back and say we do have primary insurance for her. Medicaid is currently her secondary, but there's a lot of these services and supplies that our primary insurance doesn't cover. And so Medicaid picks up the cost of those, and it's been an invaluable thing for us to have. Some of the bigger ones are some of her durable medical equipment, and they're not necessarily what you would think when you think durable medical equipment. We've gotten a stroller for her that is stroller wheelchair because when she was younger, she eloped, and so we needed the stroller to keep her safe. We had a car seat that had a higher weight limit. Again, because she eloped, we had Project Lifesaver, and that had a monthly fee. And Project Lifesaver is like a device that she wore that was linked through our sheriff's office. And if she were to run off, we could contact the sheriff, and it radio frequency, but that had a monthly membership fee, and Medicaid covered the cost of that. And she also gets respite care, which is vital for us as parents. And she qualifies for medical daycare because she's 14 and she can't go to a traditional daycare setting. So she qualifies for that medical daycare hours as well. Probably the biggest, most recent way we have really utilized our Medicaid is she has dealt with severe sleep apnea her entire life. We've done every preventative surgery we could do. She does not tolerate CPAP or anything due to lots of sensory issues. And so there was a new sleep apnea device that is an implant, but our primary insurance wouldn't cover it because she didn't meet their criteria. She met the device's criteria, but not our insurance criteria. So I actually contacted our state Medicaid director and explained the situation to her and said how this would be such a beneficial surgery for not only my daughter, but all individuals with Down syndrome, because it's a very common, sleep apnea is a very common disorder among that population. And I said how important this would be and really life-changing this device would be. And so I worked with Iowa Medicaid, and they opened up the billing code to make that device accessible for Medicaid recipients. And she actually had the surgery last month, and it has been very successful. And that is all thanks to Medicaid, because our insurance would not cover that for her. And so right now, like I said, she's 14, so she is still on our primary insurance, but she's not going to be 14 forever, and she's not going to be on our insurance forever. So it does become concerning when we're talking about these cuts, and I start thinking about what her future will look like if there's cuts to Medicaid, and what that looks like for her and for our family, honestly. Where is she going to live? How is she going to get medical care? And how are we going to maintain all of these specialists and everything if these cuts were to happen? And it's it's very unsettling and it's very concerning as a parent to try to navigate what that future would look like with these potential cuts. And that's assuming, I mean, disability doesn't discriminate. And my husband and I could become a part of the disability community at any time too. I mean, we don't know what the future holds for anybody. And so to have this little bit of stability potentially taken away is, yeah, it it puts a lot on what the future looks like for our family and for my daughter and what her independence, her level of independence could look like too as she gets older. And really that's the goal for everybody, is to have an independent life. And I feel like these Medicaid cuts really would affect her potential to live an independent life as she gets older.
Well, thank you, Emma. Thank you all for that extraordinary testimony and the rich, rich data that you've given us to talk about. Could I ask the panelists, David, Galila, Emma, and Nicole, to make sure your sound and your video are on now, because we can have a few minutes of conversation among us. I also would urge panelists to ask each other questions. I'll tee up a few, especially that I'm picking up from the Q&A, but please feel free to clarify with each other. Let me start with you, Emma. One of the things that's evident in your story is how much Medicaid covers in terms of essential needs for your daughter, way beyond just direct healthcare. It's a pretty comprehensive picture you're painting right now that could get seriously damaged. You seem to me to be the quarterback. The amount of effort you're putting in as a mother and a loved one to your daughter is extraordinary. Thank you on her behalf for all of that. What does it mean to you when you read in the newspapers that Medicaid recipients are undeserving, or there's waste, fraud, and abuse going on there, or that we have to have people forced to document that they're seeking work? What's the experience for you seeing that?
I mean, it's almost unironically funny when they say that there's so much fraud and abuse, because they've clearly never, ever had to apply or do the paperwork or maintain your status on Medicaid, because I don't even know how you could fake your way through that, because my daughter has a very visible genetic disorder. And every 3 years, we have to prove that she still is, in fact, disabled and qualifies for these services. So the fact that there's all these claims that there's so much abuse and fraud, my experience dictates that it would be really, really hard to do. So it is very frustrating, because they clearly don't understand how the system operates.
I just wanted to,
every 3 years you have to redocument that she has Down syndrome.
We have to do an assessment and an IQ test to maintain her benefits. So.
And that's
Nicole,
something
you had a comment.
Yeah, I was just going to say, and that's something that they're trying to make worse with the proposals. They're trying to make that more frequent. And that's demoralizing in so many ways and unnecessary. And I would also be remiss not to say that's really wasteful. And we have data on that, because when you look at, Galila talked about the unwinding, but also when you look at states that have implemented work requirements, they're massively expensive for states to put together, and states are notoriously not good at putting systems together. Speaking as a former state employee from the state of Illinois, and the Georgia program, for example, was put together at a cost of 84% administrative costs. That sounds like waste to me when there are 7,000 people waiting for services in Georgia.
You mentioned the number, Nicole, of the 700,000 people on waiting lists for home and community-based services. That's a national statistic, is that right?
Yes.
What are these people like? Who's waiting? Who are some of these people that you know?
Sure. And I would also say that it's over 700,000 people, and those are only for folks that know that there's a waiting list to be on. We know that that's actually not a full scope of the unmet need for aging adults and people with disabilities. And those are exactly the people that are on the waiting list. There is a higher proportion of people with disabilities that are on the list. And those are folks that in some states, including my home state of Illinois, might have been on those waiting lists for decades. So the fact for 10 years plus, and in states like Texas, it can be even longer. And so those are the people that are waiting, people with disabilities who, without those services, who are they relying on? Unpaid family caregivers at a cost of, according to the National Partnership of Women and Families, $1 trillion to the economy every year. So it's not like they're waiting and self-sustaining. They're relying on other people, and that also has costs. And so the fact that we're seeing these policies that would double these waiting lists, triple them, that's what we're really concerned about, because that's what's going to happen with these cuts.
Thanks. Galila, you talked a lot about the nursing home effects. What happens to people? What's going to happen to people with these cutbacks in nursing home support under the big beautiful bill? Where do those people go?
Yeah, that's a good question. So as Nicole pointed out earlier, there are mandatory services and optional services. Nursing home Medicaid coverage for nursing homes is a mandatory coverage for folks. So there's a more direct threat, I think, in terms of accessing long-term care for those who are for those who aren't receiving nursing home care, who are trying to receive those home and community-based services, like Nicole's brother, like Emma's daughter, who are receiving those services in home because they're optional. And those are the ones that are going to get cut right away. With that said, there are definitely cuts to nursing facilities that will occur in a maybe less direct way or less immediate way when states have to cut provider payment rates, when states have to they may not have to, there aren't the same sort of waiting lists for nursing homes like there are for Medicaid home and community-based services. But if there's already a very bad provider shortage, especially for Medicaid enrollees, and particularly in the nursing home context. And so there's ways that that's going to get even worse when states have to make these hard decisions to balance their budgets if they're losing all this federal funding. And then, as David mentioned, the nursing home staffing rule is really, really critical to save lives and to boost up the nursing homes, to make sure that our dollars, our Medicaid dollars or Medicaid dollars, are actually going to the care of residents, to make sure that they aren't, lounging in their chairs all day, wetting themselves because no one is there to take them to the bathroom, make sure they're not falling down because they need to get up and no one is there, that they're not getting pressure sores or other infections because there's no one there to help them. We've even heard of instances where people were choking on food because they didn't have anyone to help them. These are things that making sure nursing homes are well staffed would help prevent these really horrible preventable injuries and deaths that would occur, that are occurring and need to be reduced. And so in that way, I think that's a more direct way that revoking the staffing rule, which is what this bill aims to do, that's a really direct way that nursing home residents would be harmed.
John, if
you
I could,
said yes, please, Dave.
Thank you. If I just add a couple quick points, I think, as mentioned earlier, a lot of the folks who work in nursing facilities, as well as a lot of people who provide caregiving for those who need care in the community, are on Medicaid themselves. So these onerous work requirements will very likely lead to a lot of folks who, for whatever reason, are unable to meet the paperwork requirements from losing Medicaid coverage. And one provision that's also worth mentioning in the Senate bill is when you go on Medicaid long-term care, there's a period where you can get some retroactive coverage, and usually that's 90 days. And this bill would shorten that period to a month. So you actually would be a cut in the time period when people could actually get Medicaid coverage for long-term care.
David, while you've got the mic, a couple of quick questions for you. One is, there's a question that about states like New Hampshire that have trigger laws that would reduce Medicaid as Medicare dollars are cut. Can you explain that, and do you understand the situation?
Sure. I think it's quite possible that either Galila or Nicole can explain it better than I can, but the way I understand it is that certain states have requirements that their budgets be balanced, that they can't exceed a certain spending levels. And if we're contemplating a massive reduction in federal dollars going to states as a reduction of cuts in Medicaid payments, that leaves states with some really tough choices of what they're going to do. And some states are required to reduce their expenditures accordingly. And as Galila outlined, when it comes to Medicaid, some services are mandatory and some are optional. And where nursing facility services are optional, mandatory. Home and community-based services tend to be optional. And I know there's research out there, including Allison Barkoff, the former director of the Administration for Community Living, that shows that in the past, when Medicaid funding has been cut, home and community-based services is one of the first things to go and to be scaled back and to have a reduction in availability of services. Was that about right, Nicole or Galila?
Nicole or David, but there's also a question about amyotrophic lateral sclerosis, ALS. People who are suffering from ALS, and that the effect of this law on them. Do either of you have comments on that, or anyone?
Well, certainly community. I know that we partner with the organization I Am ALS, and there's a lot of concerns from their founders around this because home care is such an important resource and respite for people who have ALS and the family caregivers who are taking care of them. And so just like in ALS is obviously a horrible disease, and so many other chronic illnesses and disabilities where you really rely on that direct care workforce and those home care services, all of that is particularly at risk. And that's why we know that the ALS community is also engaged in protecting Medicaid because there's a lot of those folks that also need those services and might not be eligible already. And that's going to get even harder if these cuts come through.
Can I ask? Yeah, go ahead, please.
I'm sorry, I'm just going to add in real quick that
no, please go ahead.
Yeah, sorry. I was just going to say that ALS, as David mentioned, is a group that's eligible for Medicare under 65 if you have that diagnosis and meet the criteria. And so that is a group that would benefit from not only Medicaid through direct care workers and through HCBS to provide more holistic care, but also to pay for that care. Medicaid would provide some of those Medicare subsidies through the Medicare Savings Program. So that is a group that could face, potentially hundreds of dollars a month for years and years and years if they don't have the protections from the Medicare Savings Programs to make their Medicare more affordable on top of their Medicaid services.
Thanks a lot. There have been some talk and I've read things about Medicare sequestration or the sequestration implications of the big beautiful bill. Do any of you have any information on that?
Well, as written, at least on the House side, the bill, because of sequestration requirements, would trigger massive future cuts to the Medicare program. Nearly $500 billion in Medicare cuts would be required. However, Congress can choose.
Back up there. You said $500 billion in Medicare cuts.
$500 billion, yes, with an estimated $45 billion occurring as soon as fiscal year 2026. Now, Congress can sidestep that if they so choose, but at least in the House version, as it was written, this would require these massive sequestration cuts.
So how do you cut $500 billion out of Medicare? What would be the nature of such cuts if they occur? Payment levels?
Well, maybe I'll turn that back around to you as someone who used to run the Medicare program.
Well, I imagine,
how would you do that?
It would affect levels of payment to physicians and hospitals, and also anything discretionary in benefit structures that could be implemented.
Right.
That's a scary number. I think you've done a great job dealing with the questions that I had. I wonder if we could open the chat further for people from the audience to type in their questions. I had a couple more, but I'd welcome you all popping in. I want to go back to the vulnerability of rural hospitals. Emma, I think you said you live in a rural area. Is that right? So could several of you comment on what's going to happen to the small and rural hospitals in the country if this bill goes ahead?
So I'm actually on our local hospital board of directors as well.
I see you're going to deal with it.
And we've had discussions on how these cuts would affect payments and overall operation of the facility. Because we do live in a lower income area, so we do have a lot of Medicaid patients. So if it's a domino effect, and I think we all know that, and which it's going to affect people that do have primary insurance in as well, because if you don't have the providers, if they're not getting paid, we don't have the providers. So none of it. If you don't think it's not going to affect you, or if you think it's not going to affect you, you're probably wrong. It's going to affect you directly or indirectly somehow.
Definitely. Rural hospitals were certainly closed. Also, rural nursing homes, which are very often the only source of care all over. You also have community health centers, to Emma's point, to just double click on Emma's point. Every community will be impacted, and every community member, by these cuts, because of the way that hospital systems and community health systems rely on Medicaid to keep their doors open. There's not a doubt that every community will be impacted, but it will have a bigger impact in rural communities, which means that there will be deserts without care, without health care.
Lila, what does it look like from your point of view with rural areas in care for aging people?
Yeah, I think everything that Emma and Nicole stated is right on, exactly right. Like, there's already a massive care desert in these rural areas, and that's only going to get worse through the direct cuts made in this bill, as well as indirectly. Like we said, if provider payments are cut, if there's more restrictions, if people lose coverage. And I think one overarching theme here is this idea that if people lose their insurance, that they're just suddenly not going to get sick, like they're just going to delay their heart attack or their strokes until they get insurance again. And that's not the case. They're just going to go to the hospital, have uncompensated care, be in massive debt. The hospital is going to be come out of pocket and not have any revenue. And that's how this really impacts rural areas. And so I think that's just one underlying assumption that's not being said by people who are proposing these cuts, is what happens not only to the people themselves who are going to lose care, who could die, who could face really, really grave injury to themselves, but also to these hospitals and these communities. I used to work in a state that was, not a super Medicaid friendly state, but they ended up adopting Medicaid expansion fairly recently because of the impact that uncompensated care has on rural hospitals. And so even in areas that are not super liberal or not super progressive, they really, really relied on Medicaid to provide care to their communities. And so I think that's a really important note for members of Congress to recognize, is what is the effect? What happens to these hospitals in the long run when there's massive more people who are uninsured?
Thank you. Questions have started to come in the chat. I'd like to make you aware of. I guess there's one question has arisen about reversibility and irreversibility. We don't know how long this administration will be in place, or the people who are in sympathy with this direction of cuts. How much of this damage could be repaired in the next administration, should it be so minded, and how much is going to be hard to reverse? David, maybe you'd be willing to start with that.
Sure.
Have you seen irreversible damage?
Some of it may very well be. And I'm going to take a page from our friends at the Center on Budget and Policy Priorities. And I highly recommend that folks interested in all of these topics check out their resources. They've written a lot about the potential impacts of this bill. But I remember folks from Center on Budget saying that when it comes to battling cuts in healthcare, it's one thing dealing with reductions in payment. That's something that can more easily be replaced. But if you start dealing with the structure of the program itself, that's a lot harder to reverse. And it takes a lot more effort to fix the structure rather than to refill the proverbial tank.
Any others of the panelists have a comment on this issue of reversibility or not?
In terms of Medicaid, I agree with David that I think there's a lot of it that will be irreversible. And if you look at what has happened with the SNAP program, when you allow work requirements to be put into a program, it's really difficult to pull them out. And so it's not just the cuts that will have irreversible damage. It's when you put those types of policies in place, it gets harder to pull them away because states have already put the money in that they were required to spend. And so it's really important that we don't just save the programs in their integrity, because these would be historic cuts to Medicaid, but it's also about the actual proposals that we don't want to be allowed to be implemented into Medicaid.
I'll just also add that there's a decent chance that policies could be made worse. Again, like we've seen in the SNAP program, not only were work requirements added and with other public benefits programs, but they've gotten more strict and more restrictive and more restrictive over the last 20, 30 plus years. And so that's a real concern as well, is not only could they not be reversed, but some of these really restrictive measures about, redeterminations of proving your eligibility. Like Emma said, it is not an easy process to get approved for Medicaid or to keep your Medicaid. And we've seen in other programs that if the political winds are right, that they could just get even harder. So there's always that effect as well. We hope that if anything is impacted, that we could revoke those changes and make Medicaid more accessible for people. But I think that's also a really big risk as well, which is why we really don't want any of this to be moving forward.
Imagine the workforce distortions that you've talked about, Galila, for supporting people in nursing homes and home community-based care. That's not so easy to reverse either if people have left the workforce. Let me read verbatim a question that came in. It's a little bit complicated, but it's asking you to be consultants to healthcare organizations. Here's the question: given the potential long-term impacts of this budget reconciliation bill and Medicare, Medicaid, and home and community-based services, what strategies should mission-driven care businesses be considering now to future-proof our models, especially those serving marginalized aging populations who already face access disparities? So this is about how to be robust as a care provider organization under these really, really draconian cuts. I don't know who wants to take that one on first. Galila, what would you advise people involved in giving care to the aged people to make this more robust against these draconian cuts?
Yeah, that's a great question. And I know others probably have better insight as well. So I'll just say that one thing that has been really powerful is sharing your stories. We have a lot of great data from partners and a lot of great resources. I think that one thing that especially members of Congress and staffers need to hear is who is affected by Medicaid. They paint a picture of a stereotypical Medicaid recipient that's not very representative. So I think that's one of the best things a person can do is share their stories with press, with members of Congress, with friends, with families. I think another quick note I'll add is people might not realize that the program they're receiving is Medicaid. Because it's a joint program by federal and states partners, that states have different names for their programs. It could be the Healthy Living Program, it could be Badger Care, it could be Palmetto Care. And so just making sure that they realize that the services that they're getting are at risk and what that means for them is really important.
Thanks. Well said. Yeah, it sounds like 27 states, I think, don't call Medicaid. So the public can easily be confused. Others have any comments or recommendations to people that are giving care under these conditions now?
Well, just to reiterate what Galila said, align yourselves with people like Emma who have the courage to tell their own story and the impact that different changes will have on them personally and their families. And if possible, if you're delivering services that provide care that ward off future more expensive care, try to connect the dots and show that, changes to the structure could be penny wise but pound foolish by ending up costing more in the long run. Those arguments don't always resonate, but the personal stories certainly do.
Yeah.
Yes. Nicole, looks like you wanted to add.
Yeah, I was just going to say, I would obviously agree with all those points. And I would also add making sure that just, yes, engaging family caregivers and people with disabilities and aging adults who rely on it, but also lead with the workforce and make sure that if you're a provider organization, that you're really centering the voices of the workers and the way that also you're a job creator, because that's also been an economic argument that has been helpful, and really making sure that we're showing all of the ways that there is this interdependence of workers, providers, and families and people who need care has been an effective strategy for us.
Everything's connected to everything else. This idea that it's just them, it's just so wrong. It really strikes me as something to speak up about. We're closing in on the last couple of minutes of time. I want to ask one or two more questions with short answers. The vote on the bill is coming up in the Senate allegedly on Wednesday and the House on Friday, I think. Is that right? What do we know now about where the votes stand? Does anyone want to take out a crystal ball on this?
Well, I don't think that timeline's quite right anymore. What I've heard more recently is that that Votorama, which would be when the Senate is voting around their version of the budget reconciliation bill, will be over the weekend, and that the goal is for them to keep the House of Representatives until early next week, which means I would point out that we're already doing a good job in doing what we're supposed to do as advocates and slowing them down. And so that's the current piece in terms of how folks are going to vote. That remains to be seen. They're still doing a lot of jockeying around the policies. There's some members from some states who have more concerns about work requirements or more concerns about provider taxes or some of the different kind of wonky topics. And the fact that they're still doing that jockeying indicates that that we still have some room to push back. And the most important thing is to make sure that every senator remembers how many people with Medicaid, how many people in their states that rely on Medicaid and Medicare, because as has been clear, $500 billion of cuts to Medicare would be extremely harmful to the program. And hopefully we can slow them down. A lot of us spend a lot of time thinking about 2017 because it was similar levels of cuts that were being proposed. And at that point, they were still voting in the Senate in late July. So I would say our goal is to keep raising these concerns in every community so we can keep dragging it out and ultimately win against the cuts.
Thanks for your work on that. David, one final 15 seconds from you, a restatement that this bill is not just about Medicaid, but Medicare will be heard. Can you just go back, summarize quickly?
Sure. To some of the points you made at the outset, Don, that it is all interconnected. And you make a change over here, it will have both intended and unintended consequences over there. And I think it behooves folks to really look at connecting the dots in this bill. Red tape is being added with the result of people achieving savings by people losing coverage. I don't think that's said enough. Red tape by instituting work requirements, by more frequent eligibility verifications, and as Galila talked about, taking apart something that was meant to streamline access to Medicare savings programs will result in fewer people accessing such services, which will result in the savings for which Congress is seeking to pay for the other changes they want to make.
Thanks, David. Make no doubt about it. Everything's connected to everything else, and harm to Medicaid is harm to Medicare, and harm to Medicaid and Medicare is harm to almost everybody in America. Let me just thank you all, panelists. Fantastic conversation. And I really appreciate the many of you that have dialed in to listen to this. The recording will be available, and I hope we can keep this conversation alive. Thank you all, and have a good day.
Thank you, Don. Thank you, everybody.
Thank you.